Potassium is an essential electrolyte when it comes to regulating electrical activity through the heart. We know that when potassium levels increase, so do the cardiac complications, including cardiac conduction abnormalities, cardiac dysrhythmias, and even cardiac arrest and death. One helpful way that the effects of hyperkalemia were described to me as a student was to think of the EKG strip as a string, and imagining someone pulling the ends of that string outward, with the severity of the hyperkalemia being directly correlated with the extent of how far the string is being pulled, until the string is pulled flat and the patient is in asystole or cardiac arrest. The definition of hyperkalemia is any serum potassium level greater than 5.5 milliequivalents per liter. After this, you'll start to see a stepwise progression of cardiac conduction abnormalities. Initially, you'll start to see repolarization abnormalities. This is usually the earliest sign of hyperkalemia. In this case, you'll spot it on an EKG strip as peak T waves. At levels greater than 6.5 milliequivalents per liter, you'll start to see the P waves widen and flatten out, and eventually, the PR segments may lengthen and even completely disappear. When the serum potassium levels rise above 7 milliequivalents per liter, you'll start to see a widening of the QRS complex. You might also notice the heart rate begin to slow and even profound bradycardia. It's also not uncommon at these levels to see conduction blocks, things like bundle branch blocks, vesicular blocks, and high-grade atrioventricular blocks with ventricular escape rhythms. As the potassium levels start to get closer to 9, the EKG strip develops a sine wave morphology. In the setting of hyperkalemia, this sine wave pattern should be alarming, since this might suggest impending life-threatening cardiac dysrhythmias and cardiac arrest. Once potassium levels start reaching 9 milliequivalents per liter and greater, people start dying. EKGs start to become grossly abnormal, and patients start going into cardiac arrest. We're talking about sine wave EKG patterns morphing into a wide complex rhythm, pulseless electrical activity, asystole, and severe bradycardias, and in some cases, even ventricular fibrillation. There's one important point I want to make. It's that this progression of cardiac dysrhythmias with serum potassium levels is not a hard and fast rule. It's a nice guideline to follow in cases of hyperkalemia, but even patients with normal appearing EKGs in the setting of high potassium levels can suddenly develop cardiac arrhythmias and go into cardiac arrest. So to recap, at potassium levels greater than 5.5 milliequivalents per liter, you'll start to see peak T waves. Remember that this is the earliest sign of hyperkalemia that you might notice on an EKG. At levels greater than 6.5 milliequivalents per liter, you'll notice widening and flattening of the P waves and lengthening of the PR segment. At levels greater than 7 to 9 milliequivalents per liter, you'll have a widening of the QRS complex, including the development of a sine wave pattern as serum levels get closer to 9. At levels greater than 9 milliequivalents per liter, patients start presenting in cardiac arrest,